Hi, my name is Carl Elbing. I worked as a critical care nurse in ICU for a very long time. I did intermittent hemodialysis and CRRT. And as the ICU nurse doing the dialysis and the CRRT and using the Swan-Ganz catheters and being familiar with SVO2, I feel like I had gained some insight into the use of hematocrit monitoring when that arrived. And the hematocrit monitoring really threw me for a loop because I found that I really didn't understand fluid shifting in patients until I had my experience with this device. So I wanted to share what it is that I've learned about it. So, what is continuous hematocrit monitoring? Continuous hematocrit monitoring is when we use a device to continually monitor and graph hematocrit during dialysis. I suppose it could be used in other situations too, to assess whether patients are actively mobilizing or actively third spacing fluid. I felt that the most trouble I had in critical care was when we had very sick people who were post-ops, or they were going septic, or they had major surgery, or they were 5 days after surgery and they were terribly third spaced, and we didn't know whether or not we could get at the edema that they had, and we didn't know whether or not the patient was going to recruit the fluid if we tried to remove it. And the problem was that if we didn't understand that well, we could remove too much fluid and cause our patients a great deal of harm. So when I first was introduced to the continuous hematocrit monitoring, I really felt that I finally had a tool that I could use to decide when it was that I could remove fluid on my patients and not crash their blood pressures. So the main functions of these devices are to monitor hematocrit continuously, like I was talking about, and then to measure oximetry continuously. So if you have a patient who has an arterial access for dialysis, then you're going to be measuring SaO2, which is helpful. But I think even more helpful is that if your patient has a venous access, then you're measuring SVO2. Now, SVO2, I think, is extremely important and helpful also in determining whether or not we should or should not be removing fluid from patients. Because as you know, if a person's blood pressure begins to drop, they'll compensate. They'll compensate by clamping down. Or we might compensate for their dropping blood pressure by clamping them down with, norepinephrine or some other vasopressor. So if I'm removing fluid from my patient, and they're tolerating it well, my SVO2 should stay about the same. If I'm removing fluid and they're not tolerating it well, even if their blood pressure hasn't changed much yet, I'll see the SVO2 dropping. So if my patient's cardiac output is dropping, their oxygen delivery is dropping, I'll see my SVO2 coming down even if I'm maintaining a blood pressure at that point. So it kind of helps me to ward off problems that could be arising. So why is continuous hematocrit monitoring important? Because it's really difficult to know whether or not a person is going to mobilize fluid. I've had patients who are very edematous and they're dehydrated at the same time. Their INO could show that they're 20, 30 liters of fluid up. Their weight is clearly very high. You can't go by a dry weight anymore. And we know they have a lot of fluid on them, but we don't know whether or not we can remove the fluid. And if we try to remove it when they're not ready for us to remove it, bad things can happen. So trying to remove fluid from patients who are unable to mobilize it or who are actually in the process of third spacing, that can be very dangerous. So as a dialysis nurse, oftentimes if I was doing dialysis and their patient's blood pressure began to drop, I'd hear from nurses out in the hall that the dialysis nurse took off too much fluid and crashed my patient's blood pressure. Well, it's really hard to know what to do as the dialysis nurse in terms of removing fluid because we don't know, at least without a hematocrit monitoring, we don't know whether or not a patient is going to mobilize fluid. So this is what I mean. If we had patient A who has, say, we're removing 2 liters of fluid from them, and the patient is third spaced, but they're actually refilling their vascular space at the same rate that I'm removing fluid, then their preload will never change. If their preload doesn't change, their CVP wedge don't change, their stroke volume doesn't change, their cardiac output doesn't change, and because of that, their blood pressure doesn't change. So everything could go very well with patient A, But let's say we had that exact same patient in a parallel universe, and we called that person patient B, and I start removing fluid from that patient, and this patient, let's say, is not recruiting fluid from their third space at all. So we might be able to, he might maintain blood pressure for a while by clamping down, or maybe I'll try to help him with the pressor. But as I remove fluid, if he's not refilling his space, then his blood pressure is going to go away and he's going to do very bad. So let's look at this in a little bit more detail. The average 70 kilogram person has 5 liters of fluid intravascularly, 17 liters of fluid interstitially, and 23 liters of fluid intracellularly. So dialysis removes fluid from the intravascular space. It's that little 5 down there, that little 5 liters, that's where we're taking fluid. So when patients are becoming edematous because they've had trauma or surgery or something like that, the fluid from the intravascular space is leaking into the interstitial space and into the intracellular space, so they're actually becoming drier, even though they're becoming heavier because we're probably giving fluid to try to maintain their intravascular volume. So if you could imagine, blood pressures could drop in a hurry if the patient isn't able to refill their intravascular space from the interstitial or the intracellular. So just to recap that a little, so I'm not confusing, when a person has surgery or trauma or sepsis or something like that, fluid moves out of the intravascular space into the other spaces. And then as they get better, they heal from whatever the problem is, that fluid then comes back into the intravascular space. So when fluid is leaving the intravascular space, we should be giving fluid. When fluid is returning to the intravascular space, we should be removing fluid. It's really hard to know when exactly that's happening. So patients become symptomatic. I mean, it's a little bit textbook, but they become symptomatic when you remove about 15% of their blood volume. So if you have 5 liters of fluid in your intravascular space, 15% of that is 750 cc's. So if we take way more than 750 cc's of fluid off patients on dialysis all of the time, and the reason that we're able to do that is because when we're removing fluid from the intravascular space, they're refilling their intravascular space from their third spaces. So the crit line can help us determine when exactly that is happening. Crit line is one of the brands of hematocrit monitoring devices that I worked with. So when a person is third spacing fluid, after surgery, trauma, sepsis, you can see the intravascular space is spilling out into the interstitial and intercellular, like I was talking about, and then it returns. So to recap that, surgery, trauma, sepsis, patient's third space fluid, and then at some point they bring that fluid back in. We don't know when that's happening, though, if we're not able to monitor when that's actually happening. Hematocrit monitoring gives us information on exactly when to give fluid and how much, and when to remove fluid and how much. So how does this work? So any nurse in critical care has seen hemoglobins and hematocrits drop after they've given a fluid bolus. We attribute this to dilution, right? So you're giving a report, you say, yeah, his hemoglobin came down, but he's not bleeding. It's because I gave some fluid boluses. It's because the blood is dilute. This is exactly the same principle that's used for continuously monitoring hematocrit. If we give fluid to patients, hematocrit drops. If the fluid balance on your patient stays exactly the same, then hematocrit doesn't change. If we remove fluid, we make them drier, then their hematocrit comes up. So here's my kind of a poor graphic of continuous hematocrit monitoring. The 0 in the middle means there's 0% blood volume change. The positive 5 and the positive 10 going up are saying there's a 5% and a 10% blood volume change. And then the negative 5, 10, 15, and 20 are negative volume changes. So blood volume change is the opposite of hematocrit. So when this graph goes up, like the graph that you're seeing right here, that means that the person's blood is becoming more dilute. So their blood volume must therefore be increasing. So if we have an increase in blood volume, like as on this graph here, you see that 0, and by the way, at the bottom there, the 1 through 8, that's supposed to be time. So as time progresses from 1 to 2 to 3 to 4 to 5, you can see this person's blood volume is increasing. So their intravascular volume is increasing. So if that's happening, well, we could have an increase in the CVP and wedge. And whether or not the person's wedge or CVP, or I'm sorry, whether or not the person is actually having fluid removed or added at this point is inconsequential. Whatever is happening, this person could have had Lasix, but they're recruiting fluid faster than they're peeing it out with Lasix. I mean, what's neat about continuous hematocrit monitoring is it's actually showing you what's happening intravascularly. So this graph shows an increase in blood volume. Right here, you can see that there's like virtually no change in blood volume. So on this person, the hematocrit doesn't change, so you wouldn't see a change in the CVP or in the wedge pressure. So their intravascular volume has stayed the same. In this example right here, you can see that the blood volume is dropping down to like a negative 10% down there. So there's been a decrease in blood volume on this patient. So they've had a decrease in the wedge pressure, and they've had a decrease in the CVP, decrease in stroke volume perhaps. But anyways, this is showing a decrease in intravascular volume. So what kind of person would we want to see this type of a graph on? If this is a 4-hour dialysis run, and I know these numbers at the bottom are a little bit confusing, but if those numbers down there represented a 4-hour dialysis run, this could be a person whose fluid volume is increasing. So if you have a patient who's dehydrated, if they're dry, if their CVP is low, if their wedge is low, then this is the type of person that we want to see a positive deflection on the graph here. So the thing is that if you have somebody who's very sick, then or is very septic, they could be third spacing a great deal of fluid. So this, just imagine hypothetically that a person was third spacing 500 cc's an hour. So if we were returning 500 cc's an hour to their vascular space at this, and they were third spacing at 500 an hour, there'd be a net change of 0 in their intravascular space. So what this graph is going to show me is that I'm actually giving fluid to the patient faster than they are third spacing it. Now, they might not be third spacing. They may just be dry and they need to have a little bit more volume, and it stays in there when we give it. But the point is that you don't know if the volume has stayed inside of the intravascular space if you can't see a representation like this on the graph. You could give 500 cc's of fluid to a patient and they could third space all of it plus more. And if that happened, you'd see the next graph, which is you'd see a decrease in volume. So on this graph, this is what you would want to see on a patient that you want to remove fluid from their intravascular space, because this patient is hypervolemic. So you want to decrease their CVP, you want to decrease their wedge pressure, so we want to see a percent blood volume change. We want to see fluid being removed from their intravascular space. So this graph here is showing that some patients we might want to maintain the same intravascular volume on. So in all honesty, I felt like this was most often what my situation was in critical care, because in critical care, my patients weren't chronically fluid overloaded. They weren't chronically dry. We were very attentive, and we did the best that we could to make sure that these patients, were at the preload that they needed to be at. We watched CVPs and wedges or whatever other gadgetry that we had to try to make sure we were maintaining intravascular volume. So basically what I wanted to do in critical care most of the time, if I had a preload right where I wanted it, is I wanted to remove fluid. I just wanted to remove fluid at the same rate that the patient was mobilizing it from their third spaced areas. So if I removed 500 cc's of fluid an hour and they recruited 500 cc's an hour, then by the end of a 4-hour run, I've removed 2 liters, but I did not change their wedge and I did not change their CVP. And to me, that was what the magic of this device was, is that in hemodynamically unstable people, I could remove fluid at the exact same rate that they were recruiting fluid so that I did not change their CVP wedge, their stroke volume, or cardiac output. And that didn't mean that I didn't remove a great deal of fluid on patients. I remove 4 or 5 liters all the time, oftentimes with the help of albumin. But the point is that if I did give something like albumin, for example, then I could turn up how much fluid, the fluid removal rate, and I could remove fluid at that rate that it's being recruited, and have some time left over by the end of the run when the recruitment is kind of stalling out now from the albumin, to make sure that they're maintaining their volume and that they're doing well. This also could be, though, that I have a patient who's a trauma, a patient who's septic, somebody who's just third spacing a great deal of fluid. I have put patients on dialysis and I'm not removing fluid at all on them, and yet their blood volume is actually going down. I've seen patients, the curve on this graph here would be actually going down because they're third spacing fluid actively, despite the fact that I'm not removing anything. So on those patients, if they were at the wedge and CVP and intravascular volume that I wanted them to be at, then I actually needed to be giving fluid on dialysis to maintain them at that intravascular volume that I wanted them to be at. So that ended up kind of being, where the graph that I tried to achieve was something sort of similar to this, but perhaps between 0 and -5% is kind of where I stayed, because that was a pretty safe zone where I knew that I wasn't going to dehydrate the person to the point where they were being symptomatic, but I was taking off some fluid, and it seemed from my experience actually that I had to start removing some fluid in order to get them to start mobilizing fluid. And so this is the graph that I shot for most of the time. What I found is that, for example, if a patient was septic or had surgery or something, they were third spacing fluid for the first couple of days. So I was giving fluid sometimes on dialysis. And then later in the week, I was taking extra fluid off. But the point is that whether they were third spacing fluid or they were recruiting fluid, my job was to maintain the same intravascular volume, and I knew exactly how to do that because I could watch their hematocrit being graphed continuously. If they started drying out, I could slow down how much fluid I was taking off or give them fluid. If they started recruiting fluid in a hurry, then I could remove the fluid at the same rate that they're recruiting it. So it worked very well. I have to admit, I really thought that I was going to end up having to do more dialysis runs, or more ultrafiltration at least, if we let the patients lead the dance, in a sense, with fluid removal. But in all actuality, I think we did less dialysis runs, less ultrafiltration runs, because we were able to remove the fluid when the patient wanted it off. So sometimes a person might want 5 liters of fluid off, as evidenced by the graph on the crit line, and we would just take it because we could see that they were maintaining their intravascular volume. Knowing that I don't trust gadgets implicitly, I always would correlate this with patient conditions, and if you had SVO2, then you could see that what we were doing was see if it was affecting the SVO2, which is just a very good indicator of the impact that we're having on oxygen delivery and consumption. So I just want to go through some patient examples real quick here. I just have 3 of them. But in my first patient here, I had a patient who had a systolic blood pressure around 100. Now, I'm a little bit foggy. I don't remember all the details. So I just put in here a few points that I thought had value. This was a patient who was in respiratory distress, and she had a SVO2 around 55% when I put her on the device. The doctor did not want any fluid removed from her. He wanted her to have a net fluid removal of 0. So, but he wanted albumin. So I gave albumin at the beginning of her run, and her intravascular volume actually climbed up to a positive 8%. And by the end of the run, she ended at the positive 8% of intravascular volume, meaning that intravascularly she had more fluid on. Her blood pressure came up, and her respiratory symptoms resolved, and her SVO2 increased by 10%. So she had a net change of fluid balance of 0, but she had more intravascular volume because of the albumin. So her INO and her weight didn't change at all, but she was dramatically improved. And just a note about her systolic blood pressure of 100, I mean, that seems like a good pressure, right? But the problem when looking at blood pressure is it doesn't really tell you whether, what the cause of that blood pressure is. So a little equation I have here at the bottom says that mean arterial pressure is equal to cardiac output times systemic vascular resistance. And so this is just a simple math equation. So with this particular patient, if she was dehydrated, her cardiac output would be low, and she would try to clamp down, to maintain her blood pressure, so she would have a low cardiac output and a high resistance. So she still would have a good mean arterial pressure, but it would be with a low cardiac output and high resistance, causing her to have distress. So when her intravascular volume went up, that would improve her cardiac output. She would stop clamping herself down, so her resistance would come down, and that would help the cardiac output also. And she could even have the same blood pressure. Hers was higher, but the point was that she then had cardiac output blood pressure, not resistance blood pressure that was, caused by dehydration. So it was very helpful to be able to have the SVO2 on her. And if I was just looking at blood pressure, I might have thought that that was a good blood pressure for her. But having SVO2 and actually being able to watch her blood volume change helped me to understand what was happening with her and why it is that she actually felt so much better at the end of that dialysis run. Next patient was a patient that I had that was a cardiac surgery patient somewhere around post-op day 4 or so, and was doing very well. I gave albumin to him at the beginning of the dialysis run, and in retrospect, I might not have done that because if I knew it was going to happen, because he recruited a great deal of fluid. So I ended up removing 4 liters of fluid on him, more than I had anticipated. After I had given the albumin, his blood volume percentages started going up dramatically. So I could see that he was recruiting a lot more fluid than I had expected because of that albumin. But he was post-op day 4. He probably was at that point where he was ready to mobilize fluid. He probably would have done it on his own, but I really kickstarted it with the albumin. Regardless, once I was in that situation, I needed to be able to keep up with the fluid that was being recruited. So it took more fluid than I had intended. But despite taking off all the fluid that I did, he actually had a higher CVP and wedge by the end of the run because he had recruited more than I had removed. So I took off 4 liters, and he had a greater intravascular volume by the end of the run. These are the things that I never would have predicted had I not used a device like this. I didn't realize that a person could recruit that much fluid in that period of time. So my third patient example was a person who was in pulmonary edema. They were clearly very fluid overloaded, and I wanted to be able to remove intravascular volume. I wanted to see the graph on the device going down, but I wasn't able to do that. I can't remember what was happening with her exactly anymore. It was likely issues with her blood pressure, but I had to maintain her fluid balance pretty even. I had to have that graph that looked kind of straight across, meaning that I wasn't changing her intravascular volume, but her pulmonary edema was getting better throughout the run. And my hypothesis with that, at least, is that even though her intravascular blood volume didn't change, I was able to take off several liters of fluid, and those several liters of fluid were fluid that was third spaced and including into her lungs. So it was good to see that I was able to remove that third spaced fluid without changing her blood volume, even though I would have tried to take some more if I could have. But she did very well anyways. So my recommendations then, I guess, are that if you have a device, well, first of all, I don't know how I knew what fluid to take when I didn't have the device. I became addicted to it because I felt like, I may as well have ran dialysis blind, trying to take fluid off patients when I had no idea whether they were third spacing or whether they were recruiting. So I guess the message to me was just let the patient lead the dance. Look at them. If they need fluid, if you have the crit line on them and you have the SVO2 on them, then you can watch them. You can watch them third space, and then you can refill their vasculature with blood fluid boluses if you need to. If you need to remove fluid, you can do that. But the point is that I felt like my job was to assess their intravascular volume. If I liked where it was at, then my job throughout the run was to either give fluid or take away fluid and leave them at that same intravascular volume. Sometimes that meant I gave 2 liters, sometimes that meant I took off 5 liters. Because the patient was the one who was deciding whether or not I gave or took away fluid. So I also noticed that when I would pause fluid removal on the dialysis machine, that I could actually watch a person recruit fluid. So I could see their intravascular space refilling. So imagine I'm removing fluid and the graph is trending down, and I stop removing fluid. I could see the graph start trending up, showing that the person was actually recruiting fluid. And it was kind of interesting because what I noticed was that patients who were ready to move a lot of fluid recruited in a hurry. Over the course of 5 minutes, I could see the intravascular volume shooting back up. And so I could start removing more fluid on them. Patients who I noticed who weren't quite ready to mobilize fluid, the graph didn't shoot up at a high angle. It kind of slowly creeped up. And on those patients, I learned that I needed to be a little more careful when I was removing fluid because they weren't going to be mobilizing very quickly. So it was a pretty neat thing to be able to do, to be able to stop fluid removal for a minute, and or not a minute, but somewhere between 5 to 15 minutes, and see if they are recruiting fluid and how fast they were doing it, because I could kind of get a pulse of what they were ready for. So the next recommendation, if intravascular volume is good, only take what the patient wants to give you. Don't try to decrease their intravascular volume. Don't try to increase their intravascular volume. Just take what they want to give you. And I also feel that since it's really difficult to predict how much fluid to take off, that could be added into what the order for fluid removal is. For example, I would get orders, to take off 2 to 4 liters of fluid if possible, and the thing was, though, that I didn't really know whether I could even get 1 liter off of that patient, and nor could the physician, because we just didn't know whether or not the patient was going to be able to give up that fluid or not. You just don't know. So to me, it's kind of a safeguard, and I think that you can protect patients from crashing if we add percent blood volume change into the order. So let's say an order could say, for example, remove 3 liters. But don't remove more than 5% blood volume. So you don't want more of a 5% blood volume drop. That's a pretty safe parameter there, because the patient, hopefully, wouldn't be symptomatic at that small of a blood volume change. So I've had patients, I put them on dialysis and I start removing fluid, and they start dropping fast. I know that person is not going to be giving me fluid. They not only are they not mobilizing their third spaced fluid, they might even be actively third spacing the fluid. So what's nice about that is it safeguards me. It tells me that I need to make a phone call to the physician and tell them that they're not moving the fluid, and then we can readjust that order to something that's more reasonable. On the other side of that, it may turn out that the patient is recruiting fluid wonderfully, and you might be able to get 4 liters off of that patient because that's what they want to give you. So I say, let them lead the dance. If you're shooting for 3 liters, but they're recruiting fluid, faster than you're removing it, then you can make a phone call and say they're giving up more than I was planning on taking. Should we perhaps change that order? So I think that it's good to have the percent blood volume change in there as part of what the order is to make it more safe. And I thought that patients were going to need more dialysis, thinking this way, and by just taking off fluid when they wanted to give it, because I felt like in the beginning of their disease process of sepsis or surgery or whatever it was, that if we didn't get at some of that fluid, then we're going to pay for it later. And we're going to have to do extra ultrafiltration or something like that. And that's not what I actually found. I found that you gave fluid that people needed to be hemodynamically stable, to give them the stroke volumes and cardiac outputs that they needed to heal. And then when they were ready to give it up, when they were ready to mobilize that fluid, then we just took it at that time, and we took whatever they wanted to give us. So I feel that I actually had to come in and do less ultrafiltration runs once I started using these devices. So the limitations of the device is that it doesn't predict blood pressure drops that aren't related to fluid. So I had a patient once, and at least my hypothesis was with the blood pressure drop that it was related to ischemia. I mean, the patient actually was ischemic. They had some ST elevation, and their blood pressure dropped. And the first knee jerk reflex was that the dialysis nurse is taking off too much fluid. And on my device, though, I saw that there was no change in blood volume at all. So it wasn't a preload issue. It wasn't, the three determinants of stroke volume or preload, afterload, and contractility. Stroke volume times heart rate is cardiac output times resistance equals blood pressure. So because this person had an ischemic heart, I think that their blood pressure dropped because their stroke volume dropped related to contractility issue. So if your blood pressure drops because of poor contractility, then we're not going to blame the fluid. So I think that's good too, because it helps us understand exactly what's happening and why the blood pressure is dropping. And if I had been at negative 10% blood volume change because I'd been removing fluid, then I could surmise perhaps that it was the fluid removal that contributed to the blood pressure dropping, and then change that and decide that we're not going to go any lower than this particular hematocrit again. But in this particular case, it was I believe because of ischemic heart that caused a drop in the cardiac output. Also with vasodilation, if you have a person who dilates out for anaphylaxis or sepsis or something like that, blood pressure drops. It's not because of fluid removal during dialysis that causes it. It's just that, dilation makes your tank bigger. Your bigger tank means you have less resistance. And dilated out veins decrease your preload because they're dilated. So in that case, that person would probably need fluid. But if preload, afterload, and contractility are the three determinants of stroke volume, then preload is the one that we're watching with the continuous hematocrit monitoring, but blood pressure can drop because of contractility or resistance issues also. So another issue is that PRBCs, packed red blood cells, or bleeding, kind of make it difficult to interpret the information that you're getting with the hematocrit monitor, because red blood cells are hematocrit. So hematocrit's going to rise when you're giving blood. If they're bleeding, hematocrit's going to drop. So you can't look then at hematocrit as being only going up and down related to dilution, because the reason that the hematocrit monitor is working the way that it does is because it's looking at dilution to determine whether the person's getting drier or wetter. And clearly that's not what you're interpreting when you have packed red cells or you have bleeding with your patient. So the last limitation, I guess, is just that, I don't know if it's a limitation, it's just that that continuous hematocrit monitoring helps us determine whether or not our fluid balance is contributing to issues with our patients. It helps us remove fluid when the patients want to have the fluid removed, and at the rate that they want it to remove and at the amounts that they want it to remove. But there's all kinds of other things that happen on dialysis. I felt like if I put a person on dialysis that they're they had more ectopy just immediately. As soon as I would put them on, their blood pressure would have issues immediately just by putting them on the machine. They were more unstable. So I think that the hematocrit monitoring is very helpful for helping to stabilize patients, but just know that things still happen. Thank you very much.